If someone does have cancer, so we all hear that there's a waiting list to see dermatologists. There's a very few of you. You're like these unicorns in Ireland, aren't you? It's like if someone says I saw a dermatologist, like how? When?
What's your connection?
Where?
But I have had a colleague who, was on holidays and was walking down the beach, and the person in front of them had a barn door melanoma on their back, and he said it. Tapped the guy on the shoulder and said, I don't mean to disturb you, but I'm a plastic surgeon, and you really should get that mole checked out. And the abuse that he got. So my rule of thumb for everyone is if you have a new thing on your skin and it looks like a spot, if it's there for longer than 4 to 6 weeks, you need to get it checked out, because all of us can get a spot. You wake up one day, you have a spot, but that goes away. Like any average acne spot is gone within a few weeks. But if you have something that continues to change in the shape, the size, the colour, you absolutely need to go to your GP and have it checked.
On the female pattern hair loss, post-menopausal, which is when it tends to happen. Yeah. On a scale, like a lot of women, it happens to a lot of women. Is there anything that the average woman can do to help it?
But the problem for women with female pattern hair loss, it's more of a global, diffuse kind of hair loss. So their hair is thin everywhere, as opposed to the way men are more just on top. Yeah. So most women have that kind of, it's kind of like the monk-like effect with the hair around the back. And smooth on top. But again, we cannot grow back the hair, because what will happen is those hair follicles just become more miniaturized until they're gone. And once that hair follicle is gone, we can't open it back up. So again, the earlier you start treatment for that, you can maintain what you currently have.
And what is the treatment then? Sorry, I always get questions about what is the best sunscreen for babies? Nikki, it's brilliant having you today.
Delighted to be here.
So many questions about skin coming in. I think everyone is a little bit skin obsessed, aren't they, in some shape or form?
Yeah, especially in the last few years. We've had extra time with the pandemic to be on Instagram and TikTok, and lots of trends. Yeah, and a lot of them gone, but
I know, there have been like crazy trends too. But what is your special area of interest, or what do you do on a day-to-day as a dermatologist?
So I do a mixture of inflammatory dermatology, which is mainly composed of acne, rosacea, psoriasis and eczema, dermatitis, and skin cancer. That would be the main bulk of my day. Okay. Every day. And then 2 days I'm specifically in theatre, and the rest of the time I'm in a clinic seeing the patients.
So are you like Dr. Pimple Popper in the theatre? Because I need to be there. I love those lipomas and the draining the abscesses and stuff like that. So.
Like we do everything. We do obviously atypical moles, sometimes moles that are just catching, annoying people. A lot of skin cancer, the commonest would be basal cells, squamous cells and melanoma. And then the annoying things that people get, like a cyst on the top of your head, a cyst on your back that gets recurrently infected, skin tags. So a lot of benign stuff too, but sometimes incredibly annoying for the patient who's suffering with it. So my favorite thing is to take out a scalp cyst intact, like a little egg. Don't burst it, and have it in one piece.
Deep satisfaction.
Very satisfying, yeah.
And if someone has a scalp cyst and it grows out of their head and their hair kind of parts a little bit, does it just go back then once it's
because it's like it's being stretched by the essentially an egg-shaped kind of cyst underneath. So once you take it out, the skin just comes back together, just a few absorbable stitches, and the hair comes back, because the hair follicles are still there. You're not cutting a big amount of skin out, you're just making a straight line incision and squeezing it out through that. So it's not like you're cutting away a big chunk of their skin.
Okay, and what causes a cyst?
It's basically just a buildup of dead skin cells, all coming together, and there's a little wall that lines it. It just fills up and fills up and fills up, and sometimes it can be quite tender to touch, or if it's sticking out, as you said, your hair is parted, so it looks pretty obvious. You can get them anywhere on the body, and commonly patients who suffer with acne, can get nodular cystic acne or cysts in other places. But it can happen to anyone. They do run, particularly the scalp cysts. You see them in families. So often, a parent before you suffer with cysts, and then you suffer with cysts, but they can get infected, because bacteria can get in on top of all those buildup of dead skin cells, and then you end up on antibiotics with your GP. So if that's happening recurrently, you definitely want to get it removed.
Okay. So I'd love to talk to you a little bit about skin cancer.
Sure.
Because there's lots of it around, isn't there?
Yeah, I mean, it's the commonest cancer in Ireland. We have about 13,500 cases per year. But unfortunately, that's going to exponentially rise by 2040. And then we predict there'll be up to 19,000 cases in a year.
And why will it rise, do you think?
I suppose you and I are of that generation where, when we were growing up, we got those 2 weeks away in Spain every year, or more if we were lucky. And that's continued on. And basically, it's catching up on us now that we kind of went away with our pale skin, 2 weeks of sunburn, went pink, peeled, and did it all over again the next summer. But what people forget is that the sun in Ireland is the same as the sun in Spain, is the same in the sun somewhere else. So often in the clinic you hear people say, but I don't wear sunscreen in Ireland, like it's Ireland. And I'm like, what's your point? Because you couldn't get sunburnt in Ireland. And the only people in the clinic in the last couple of weeks who've been sunburnt was anyone who went to, West Cork and Waterford and Wexford and the sunny southeast, as I like to call it, and got sunburnt on the beach. And anyone who's come back from Spain, Portugal and Italy put their sunscreen on because they bring their sunscreen with them, and nobody had a sunburn.
Okay.
So it's the cumulative amount of damage over your lifetime. But obviously those recurrent burns that you get just puts you at increased risk of skin cancer. But to be honest, most of your sun damage is done as a child until your late teens, early 20s. So this generation of children, thankfully, have the rash vests. We're much more, sun smart. We have the hats with the covering on their neck. We really are more aware now. So this generation of kids are going to be the most protective.
Okay.
Thankfully.
I kind of like putting my kids out into the sun and letting them run around. And is this terrible now? Like, I like them because I feel it's healthy for them too.
Yeah, totally. I mean, I everyone when you're young looks better with the glow of a mild tan. There's no point in denying that's why there's such a big market for fake tan, because we all look much better than our pasty white skin. But the problem is any tan is essentially damage.
Okay.
So, basically if you have that even mild tan at the end of your summer, it is damage. But yeah, you do feel better when you're outdoors, the fresh air, get rid of all the winter bugs, vitamin D, all the benefits, but at the same time, it is still damaging. And, everyone is, as you said, obsessed with skincare and anti-aging at the moment. And 80 to 90% of your wrinkles are from UV exposure. So if we were all born with our lovely, clear, pale skin and we put, sunscreen on from the get-go and didn't get sunburns and didn't go out without protection, we'd look a lot younger.
Yeah, that's so true. And so do you see people coming into the clinic and the cancer is very advanced?
It's a mixture.
Okay.
Yeah. Now, thankfully, people are more sun aware, and there are leaflets there. If you're sitting in your GP surgery, you'll see from the Irish Skin Foundation, they make good leaflets on particularly melanoma, which is unfortunately the skin cancer that can spread inside. And we have about 1,300 cases a year in Ireland. But that is the most deadly one because that is the one that can spread anywhere, lymph nodes or organs.
So melanoma is a cancer of the skin, but it can spread throughout the body, or is that essentially what it is?
Yeah, absolutely.
Okay.
Yeah. So for most people, they know it as either a changing mole or a new pigmented lesion. So a new brown lesion essentially on the skin. Rarely it can be what we call amelanotic melanoma. So it can be pink. So my rule of thumb for everyone is if you have a new thing on your skin and it looks like a spot, if it's there for longer than 4 to 6 weeks, you need to get it checked out because all of us can get a spot. You wake up one day, you have a spot.
Yeah.
But that goes away. Like any average acne spot is gone within a few weeks. But if you have something that continues to change in the shape, the size, the colour, you absolutely need to go to your GP and have it checked.
Because people would have it, say, on an area that they can pick and they just kind of pick at it and, bleeds.
Yeah, like a sore that doesn't go away.
Yeah. So anything like that, they need to go and get it seen to.
Yeah, and there are lots of them that can be benign, of course, because as we get older, we get all sorts of age-related changes to our skin as well. And, there are lots of common things. If you look at the average person's back on holidays, you'll see these kind of warty looking things commonly on the back, often brown. And of course, they can get confused with moles. They're called seborrheic keratosis, totally harmless, but they can come in all sorts of shapes and sizes. So it is confusing for people as to, what's a mole versus what's a benign thing. But if you have any concerns, the earlier you get it checked, the better, because for the majority, they are curable if you catch them early. So that's
do you
the most
go around
important.
looking at people on holidays like exam?
Say that again?
Do you walk past people examining them and going, I wonder what that is?
It's a difficult one because, I haven't done it myself or had to do it, but I have had a colleague who, was on holidays and was walking down the beach and the person in front of them had a barn door melanoma on their back. And he said it, tapped the guy on the shoulder and said, I don't mean to disturb you, but, I'm a plastic surgeon and you really should get that mole checked out. And the abuse that he got. So, really? It's kind of a tricky one to say, it's not that you're just pointing out a flaw, it's that you're trying to save somebody's life. But I think I would. I mean, honestly, I wouldn't care what kind of response. I've heard everything. Once you've worked in A&E, you've heard everything. I would take it. You grow a thick skin over the years of being a doctor. And I would, if I absolutely saw something worrisome, I'd say it to somebody.
Okay. And so if someone does have cancer, so we all hear that there's a waiting list to see dermatologists. Mm-hmm. There's a very few. You're like these unicorns in Ireland, aren't you? It's like if someone says I saw a dermatologist, like how, when,
what's your connection?
Where? Yeah, exactly. So if someone has something on their arm or their leg, and they go and get seen to by the GP, and the GP thinks it's cancer. How quickly are they seen by someone like you then?
So everything, like skin cancer trumps everything else, unfortunately. And don't get me wrong, there's people out there who need to be seen with psoriasis, eczema, acne. They need to be seen with everything. But thankfully, those conditions, as much as they're severe, people will not die from it. It can be managed. Whereas with skin cancer, we absolutely want to get you in. So the gold standard of care is if a GP refers in a letter and it says, please see urgently, query melanoma, those patients will be seen within 2 weeks. Honestly, in my clinic, it's usually like if we get that letter that day, if we have a cancellation, my secretaries are just going to ring that patient and say, do you know what, are you free this afternoon? Come on in. And we usually actually see them in the same week. And then I have my next theatre list, and they're going to be put on that theatre list straight away, of course, if it is a skin cancer. So skin cancer will always get in. Now, of course, there are other not so serious, thankfully, and the most common skin cancer is basal cell carcinoma. And of course, if the GP says, query basal cell carcinoma, unfortunately, they're not going to get seen in the same week. But thankfully, it doesn't matter in the sense that they, a 1 in 40 chance of spreading internally. I've never seen it in my career to date, and it's 20 years next year. There's a case report of it. But basically, that was somebody who'd let their basal cell carcinoma take over nearly their whole back. But basal cells do not spread inside. So they're not going to take a day off your life is the most important thing. They'll just slowly grow, and become more of an aesthetic related issue, and then a bit of local anesthetic for the most part and remove it, and that's the end of it.
And what is the difference in the look of a melanoma versus a basal cell?
So for melanoma, the majority are pigmented or brown, or various shades of brown. Of course, they can have bits of pink. That's why they have an irregular colour to them, but they're predominantly brown. Whereas a basal cell is usually pink. And often if you catch it under a certain light, it has a slight pearly effect, slightly shiny. So if you kind of stretch the skin, it looks like a little shiny appearance. And they can be, if the centre of them starts to come away, it's called ulcerated basal cell. They will start to bleed or scab. So usually, you forget when people get older, it's more common to obviously have them. You might be wearing glasses, and if you don't have your glasses on, you can't see everything clearly. So if they're down the side of your face, you kind of always have your glasses on. We commonly see them here on the temples, where we don't always rub our sunscreen really well into the hairline because it's just too messy. None of us want to do it. So they're very common around the forehead and around the side of the face. And you often only start to notice it when it's a bump. But they start off flat and then they raise into a bump.
Okay.
But most people only pick up on it when they feel it as opposed to seeing it.
Right. So you can get them in, and if you can cut out the melanoma, and then is that it with the therapy, or how do you know to go further then?
It depends on the stage. Okay. So what we do with melanoma is we do not biopsy melanomas for the most part. Now, don't get me wrong, if somebody came in and their melanoma was like, the size of my hand, which would be incredibly rare, to cut all of that out in one go without knowing it's a melanoma for sure, it would be a huge scar. So we would biopsy, but you never really biopsy. So if a melanoma was the size of my nail, it gets cut out in one. So the minute it's gone, it's gone. Do you know what I mean? It's sent off for full analysis. And then we get a report and we talk about the stages. So fingers crossed, if it's nice and early, we're going to get like a stage 1 melanoma, which means that the only thing the person needs is a second surgery, for the most part under local anaesthetic, to take a little bit more skin to make sure that the melanoma never recurs at that site. So that's the gold standard of care, would always be 2 surgeries for melanoma. So you get the first one, we just remove 2 millimeters of normal skin around it. That's gone. And then when we get the level, we then take either a 1 centimetre margin or a 2 centimetre margin, depending on the stage. So it can be stage 1 to 4. And then, of course, the higher the stage goes, you might end up having scans to check internally that it hasn't spread somewhere else.
Okay.
So it's between ourselves, the dermatologists and oncologists, because there thankfully are great new immunotherapies for melanoma, things that we didn't have years ago. And we really had horrible treatments. We had interferon, which was a horrible therapy, where people it wasn't very successful, and they felt depressed and miserable and fatigued, and they were barely just getting over those side effects, and then they were due their next dose. It was awful. Whereas the immunotherapies, don't get me wrong, they have potential side effects, but a lot of my patients are living years with them with bad prognosis, like stage 4 melanoma, and they don't have significant side effects and they're living their daily life. But the whole point is to get somebody with stage 1 melanoma. Yeah. That's the whole point. So if you see something changing, get it checked.
Yeah, but it's unreal how those immunotherapies actually have in some cases made cancer, like what you're talking about, just a chronic illness that people can almost manage if they're just taking they're using their medicine. So it is unbelievable.
It has been life changing the last 5 to 10 years.
Yeah, it's unreal. So wear your sunscreen, everyone. Yeah. But
I suppose, I mean, I don't get me wrong, I love my sunscreen, I wear it every day, but it is the most expensive way to protect your skin. So like if I'm going on holidays, which I am on Friday, so the countdown is on now, I'm not going to be just with like literally string top on, like shorts and sunscreen everywhere else. I'm going to be more covered up. It's much easier to wear a long sleeve top, like a really nice shirt with your shorts, and then you only have to put part of your body with sunscreen on. It's really expensive for people with, family with multiple children. You're trying to put sunscreen on everywhere. Most people underuse sunscreen because they go away with the one bottle, share it around the whole family, and they're still packing it in their suitcase on the way back. Yeah. That's not enough sunscreen. So ideally it's a shot glass size to cover the whole body.
For an adult.
Or we'd say kind of, you can use the teaspoon. So you can kind of, like somewhere between like a half a teaspoon for your face and neck, and then a teaspoon for each limb and your torso. But yeah, we underuse sunscreen, and the frequency of application is the most important. So every 2 hours to all sun exposed sites.
And do you actually do that, Nikki?
I do, but I have the least amount of sun exposed sites. So, as I said, I would be, and I, not everyone can see you when you're on a podcast, but I have a dress on with longer sleeves and down to my knees. So I only have sunscreen on legs, hands and face and neck. Now, all year round, I have it on my face, neck and back of my hands. But in fairness, I'd be in tights for that's part of an Irish winter. So I do. And I've been doing that for years.
I'm bad at putting it on my hands. And I know that your hands are the first sign of
give away
aging,
your age.
Aren't they?
Yeah, absolutely. But I mean, I'm obviously in the routine now. And I mean, we obviously, when I was starting off into dermatology, we had our mentors and, they were saying the same things to the patients. And that's when you adopt a new life for yourself. But I mean, my parents were really good at protecting me when I was a child, but of course I missed a shoulder here or there. I have one great story. My poor dad, he's so good to us. We were in the States and the bottle of sunscreen just ran out. So he went into the hotel shop to get more sunscreen, came out with a bottle of sunscreen. I put it on. It was just I'd run out for my tummy. I'd everywhere else and put it on my tummy. And then that night I was getting dressed to go out for dinner, and I was like, God, my stomach's really sore. You're getting out of the shower in that kind of heat, and looking down, my tummy's starting to go red. I was like, I put my sunscreen on. Like, I could have a burn. And we looked at the bottle. It was a bottle of fake tan. But like, this is when I was a teenager now. So the fake tans, we went back into the shop. They were put in the same shelf in the middle of the sunscreen. So when he took out a bottle and it had a few palm trees and stuff on it, it looked like, a bottle of sunscreen. And back in the day, the fake tans didn't even have a bit of a tint. They were all white anyway. Yeah. Whereas now you can see that you're easily putting your fake tan on. So I just rubbed it all on, thinking I was putting on my sunscreen, and clearly had factor 0 on because there was no sunscreen in it, and I burnt my stomach. So if anyone tells me that they've never been sunburned, it is a true lie. We've all missed a bit of skin, and nobody's perfect. So
I did that to he's now my husband, but when we were in Gran Canaria, we were only about 20 at the time, and he got sunburned, and I gave him after sun, but it was after sun with a tint of fake tan. It was like to prolong your tan. Yeah. So we came back to Ireland, and his face was orange and peeling from the fake tan that was like
and burnt. The orange hue of the
So
I'm sure it was a great look.
I was not popular with that. So, and sorry, I always get questions about what is the best sunscreen for babies? And I know what you're going to answer.
Yeah, well, before 6 months, you're not really supposed to use them because baby skin is much thinner. So everything you put on them gets absorbed more easily. So they're just going to be much more sensitive. So if you're using a chemical sunscreen, all those chemicals get in much more easily. So ideally, I like to put them in light layers of clothing and have them in their buggy with, the hood up in the shady, and never be like lying them out at midday sun. So you're trying to keep them in the shade with loose clothes on, not overheating. But if you really had to put on a sunscreen because you just had to be outside, it would be a mineral or physical sunscreen. So the ones that contain the zinc oxide, titanium dioxide, and the one that we love the best would be the L to MD Pure, because it's just a pure physical sunscreen. So that would be for your small babies, so your infants essentially.
And does it make them go white?
No, I mean it's not a tinted one obviously for kids, but it's not a complete white cast. It does go in nicely. And then for my own little girl who's nearly 11 now, she likes the sport it on her body. It's kind of has a slight shimmer. She's all about the glitter and all that.
Of course she is.
And she also likes the one with a bit of a shimmer and a glow on her face. So
well, I use the tint one. I use the Elta MD tint. I love it. Yeah. And since I started using it, well, look, when I came to your clinic first, your nurse Claire just gave out to me for not wearing my sunscreen all the time. I know. And but it's funny because I have Celtic type skin, but I do tan. So and I'd wear it on and off, but now it's every day I wear it. And I do routine. It is a difference. There is a difference in your skin, isn't it? Like there's no point in actually spending money on your skin.
No, because people come in all the time, they're looking for anti-aging advice, and particularly with anti-wrinkle injections. Like when I'm talking to anyone who's coming to me for anti-wrinkle injections, it's like, I'm not just going to make this part from your, eyebrows to your hairline look younger by injecting some anti-wrinkle injections. It's all about, do you have a sunscreen in the morning and do you have a retinoid topically at night? Because the two of them are the most anti-aging, and everything else is the bonus on top of that. But if people just have a good skincare routine and they have a really good sunscreen in the morning that they use 365 days a year, and then they add in a topical retinoid, that's trying to prevent damage from your to your collagen by UV exposure, and then trying to stimulate some collagen, which we unfortunately all lose as we get older. So they're the best two products on the market.
Well, actually, you've just touched on a couple of questions that come in. So if someone wants a basic skincare routine that isn't going to cost them an arm and a leg, what should they use? So in the morning, it's the sunscreen. So as I said, my preference is for physical or mineral, because I don't like as many chemicals on the face. And Irish people in general have quite sensitive skin. We are rosacea prone, the curse of the Celts. So 10% of adults in Ireland would suffer with rosacea. So physical and mineral sunscreens are best for all of that. Or anyone who feels they have, eczema type of a skin, they shouldn't be putting the chemicals on because they can just get reactions to them. So that would be your morning. And then adding in your topical retinoid slowly. So less is more when it comes to topical retinoid. So people, there's so many brands on, the last few years, there's just so many brands out there, all these different percentages, and people are obsessed with getting to this really high percentage. Like, I'm climbing up the ladder, I'm gone, from 0.5%, I'm on 1%. Like, I know there's even a saying like, start low and go slow and like you'll reach your goal, but it doesn't suit me.
It doesn't suit me. Like, I have never been able to tolerate prescription strength topical retinoid. I have tried and I look worse. I have like dry skin, peeling skin. I look older because if your skin is too dry from it, it looks like these false fine lines and wrinkles. So it's not a good look. Whereas you want that kind of glowy, youthful look to your skin. So I have never been able to write the prescription for topical retinoid and tolerate it. If somebody wants to try it, absolutely, but you must put it on, allow it to dry for a few minutes, and then put a moisturizer on afterwards. Otherwise, you're going to wake up and get like snake skin. And it's, as I said, not a good look. Your makeup won't sit on it. Nothing looks good about it. But you would use it one night, you take a break of 2 to 3 nights, then you use it again, and you slowly build it up over potentially months. It doesn't happen over a week or two. Skin takes time to adapt. Like, it takes 21 to 28 days just to get one new layer of skin. Yeah. So, we all, I suppose, especially I've noticed in the last 3 years, we're kind of now this new instantaneous generation, like, because the younger kids are on like Snapchat, everything like click your finger, this is supposed to be fixed, a bit like skin. It's like, if you have a skin problem, can somebody just click their fingers and I'll magic it all away? I'm not a fairy godmother. I don't have a magic wand, but I can give you a nice big needle though with loads of anti-wrinkle injections. I do have that. But it is important to allow your skin to adapt. And if you do want to start into a new skincare routine, start slowly. And especially if you're going to add in actives like vitamin C, or you want to add alpha hydroxy acids, beta hydroxy acids, one at a time, not everything together. It's, we saw a lot of what we would call kind of casualties of the trends of during the pandemic on TikTok and Instagram, and people with their 10 products at nighttime and their 20 products in the morning. Must take them about an hour to put their lotions and potions on. But too many. And I saw people coming in with like their skin literally stripped, peeling off. Their skin barrier was destroyed, and that's going to take me months to try and build that back up. And literally they have to stop everything. Like, they cannot use any of the actives, which you've gone and spent a huge amount of money, and I'm telling you to put them all to one side.
Okay, so what kind of percentage of retinoid would you tell someone to start off on, like an OTC?
Absolutely, yeah. They range from kind of 0.2 to 0.3 for, some of the more inexpensive brands on the market. And then they can build themselves up. And if they never make it past, because they're so different, you see, if we're using prescription strength tretinoin, often we're using 0.05, but people then will go, oh, but that's only 0.05. Then I'm using that, and I'm using 0.3, and it's not quite the same.
No.
So if it's prescription strength, you can start at 0.025, then go to 0.05. They have higher percentages in the States, which we don't have.
I can't tolerate any of them.
But most Irish people can't, you know. So I don't use any of them. I use Alpha Ret by Skin Better Science, and that was a game changer for me and my patients. Because I look after so much rosacea, and I really feel sorry for patients who they get their rosacea under control and they're at that age, because it's often near like 30s and 40s, and they're like, what can I do for anti-aging? And I'm like, I can't give you anything, because like I've just gotten your skin clear, and now if I go and give you a retinoid, but I can't give them Alpha Ret. It's fabulous because it has hyaluronic acid in it, which is moisturizing you at the same time, and it's a slow release retinoid over your 24-hour period. So I've never had somebody flare using that. But again, certain products are at the higher end of the market. So if I was going to spend my money, I want my money to go on a good sunscreen in the morning and a good retinoid. And there's so many moisturizers on the market that are really inexpensive and they're fabulous. Like CeraVe, I love CeraVe. It's got your ceramides in it, so it's recreating the skin barrier. The face wash ranges from like 12 to 14 euro. It's brilliant for acne, rosacea, sensitive skin. Really good.
So people don't need to spend a lot of money on a cleanser, do they not?
No. They just need to use it properly. Like, you know, so like cleansing for like 60 seconds properly, like doing a deep cleanse. Like if you've put makeup on, sunscreen, you've been sweating, there's oil buildup, bacteria and dead skin cells, you have to wash all of that off at the end of a day. So I would normally cleanse twice. I use a micellar water and then I follow that with a creamy cleanser, but some people don't tolerate micellar water. Their skin is too sensitive and they just don't like it. So you don't have to, but I would do the double cleanse. I would use your creamy cleanser twice. Because if you get a cotton pad and you rubbed it on your face after you've cleansed once, you'll still see makeup. You'll still see, or tinted sunscreen or whatever it is, you'll still see traces of it. So you need to do your double cleanse just to especially if you're acne prone, to really clear out those pores.
Okay, so that's important. With a good moisturizer that just literally replenishes the ceramides or puts in the moisture into your skin and those actives. Is vitamin C fantastically, amazingly good on the skin?
I love vitamin C. And I actually, and maybe it's all in my head, maybe it's the placebo effect. If I didn't bring it, I didn't bring it on holidays once. I just forgot. It's so much, I feel like my suitcase is more with skincare products than anything else when I go on holidays. And I didn't bring it. And I was like, God, my skin looks really dull. But then you're like, it's different water. You're in a hotel for a week. It's not quite the same. And then I started putting my vitamin C on. And then within days, I was like, oh my God, my skin's glowy again. And I'm like, is that all in my head? Because it really worked that quickly. But I definitely feel my skin is more glowy.
But is it because it's an orangey type pigment and it's almost like as if that's getting into your skin and giving you that glow? No,
because they're all slightly different. Yes, some of them have a kind of a yellowy, orangey, but like the one I actually use is white. A white cream, and I just feel it makes me glowy. Again, that's anti-aging, has its antioxidant effect. It's stopping damage from free radicals, from pollution, and we do live in a busy city. So I do love my vitamin C, but that wouldn't be the first thing that I'd say to, everyone, you have to go out and buy this. If they haven't got a good sunscreen and they haven't even added in a retinoid, I would start with those two first.
Okay.
I would then add in vitamin C. And if you're really looking for that exfoliation and that toning, it's then when you add in your alpha hydroxy acids and your beta hydroxy acids. But if you've got really sensitive rosacea prone skin or eczema prone skin, that's not for you, because it's just gonna damage the skin barrier.
You reminded me of a time I went through a juicing phase when I was younger, and I was juicing loads of carrots and drinking them.
Did you
and
go orange?
I did.
Yeah.
I went orange. It's
not a great look.
No, it ain't. It ain't pretty. Yeah. But it is funny how that can happen. Okay, so that's great. So I'd love to go on to acne now. Mm-hmm. So first of all, what is acne and why do certain people get it?
So I suppose acne is one of the commonest skin diseases in the world. So it affects about 9.4% of the global population. That's how common it is. And about 85% of teenagers. So everyone has had a spot. But the most important thing about acne is, again, catching it early, a bit like skin cancer. So the minute you start to see a scar is when you need to actively seek treatment. But for the most part, it's teenagers who present with it. So we're ticking along fine, everything's grand. And then our hormones start to kick in, and then our oil gland starts to become hyperactive, and it's basically producing too much oil. And this is sticky, and it's basically sticking together with our dead skin cells and creating that primary lesion of acne, which is the comedone is the proper name for it, but blackhead is the common name. And you basically have all of these block spores, and then you have your bacteria, which gets in on top of it and gives you the pus bump or the red spot, or for more severe end of the scale would be the nodules or the cysts. So the deeper lesions that you're kind of only seeing the tip of the iceberg, but only the person themselves kind of feels it, really, really sore. It can be really debilitating, like a huge impact on somebody's quality of life. The amount of teenagers that I have that were, acing sports, like literally brilliant, and then don't want to take their top off in the changing room, giving up swimming, dropping out of sports because of the bad acne on their back or their chest. I'm not saying it's any easier for girls at all, having suffered with it myself, but we, for the most part, can cover it up temporarily with makeup. Whereas the average guy just doesn't put on a full face of makeup every day. No. And particularly, obviously, if it's on your back and chest, it's uncomfortable trying to put a school bag on. Like the cyst can burst. You have seepage through your clothes, like really debilitating. So some of my patients come in like they've grown their hair, big fringe down, trying to hide it. They don't make eye contact. And then to give them treatment 6 or 7 months later, it's like meeting a new person for the first time.
It's unbelievable what really good treatment can do. The only thing is, though, is that I would see in the pharmacy is that people are often, they're put on an antibiotic. And they might be tried on a pill if they're female. Well, first of all, they're putting lots of topical things. They don't work. So it's almost like they have 2 years of trying stuff that doesn't quite nip it in the bud. Then they might get a prescription for Roaccutane of someone like yourself, and that works a treat. But the scarring and all that damage has happened in the meantime. So how do we, what is the gold standard of care for acne? Do people have to go through the topical, then the antibiotics before they get to the Roaccutane, or what is it?
No, the licensed indication for Roaccutane is scarring acne. So even one scar, it doesn't have to be, 100 scars, just the start of scarring acne or acne that has failed other treatments. So in your case, as you said, the antibiotics, the topicals. But the guidelines are always being updated. And the latest guidelines from the UK came out to say that it's a trial of 12 weeks of antibiotics. And that's really should only be used for inflammatory acne. So when you can see the red spots and the pus bumps, but there are plenty of patients who have just comedonal acne. So they don't have any inflammation whatsoever. But if you look at them from the side, you can see all these tiny little bumps under their skin. So they've kind of got oily skin. It almost looks like they haven't kind of cleansed it, and loads of skin colored bumps. So they're all closed comedones or closed blackheads. So they have the dead skin cells under the surface and then a layer of skin over it. So they are never going to come out without treatment. You cannot squeeze at them. They won't come out. Please do not pick or squeeze your spots, but people try, of course. We've all tried. And they feel that their skin texture is completely different because there's hundreds of little bumps under the skin. And the best treatment for that is isotretinoin or Roaccutane. So I would have plenty of patients who, of course, tried the topicals and they might be put on prescription, full strength topical retinoid. But the average fair-skinned Irish person trying to put that on every night, they give up. And like if I was asked to use it for a week in a row, I'd have given up as well. I got acne during my pregnancy. So I was 30 when I was pregnant, and, I didn't have severe teenage acne. I had a couple of spots, totally fine. Never needed any treatment apart from washing my face. And I hit 30 and I had hyperemesis. So I literally had all those extra.
You must have been a really attractive pregnant lady, were you?
Best 9 months of my life. All the other colleagues I was working at the time literally used to laugh at me. I'd come in, my mom was like my literally life savior. She'd be giving me all these tiny little snacks, all my fresh fruit, chopped up crackers, biscuits, all this kind of stuff. I came in with about 10 Tupperwares into clinic every day trying to snack on things. And if I could keep it down for 5 minutes, like it was a miracle. But literally by 6 weeks, spots were starting to occur. All my lower face, classic female jawline, hormonal acne turned into like nodular cystic acne. And, at the very beginning of pregnancy, you're not normally telling people that you are pregnant. But by the time I was vomiting, I fainted backwards off a podium when I was giving a lecture to the whole country on a teleconference, and fainted backwards. And I was the only person in the room. So everyone else was in Cork and Galway and everywhere else. And all they see is me collapsing backwards off the stage. Oh my God. So I'd fainted, I had vomited, and my acne was coming out. And why can't it, I could see patients looking at me going, she's a dermatologist, why can't she clear her own skin? But clearly I had no bump, and my patients only actually recognised I was pregnant at 38 weeks when I was leaving to go on my maternity leave and have my little girl at 39 weeks. So they were like, oh, congratulations, did you just find out you're pregnant? And I was like, no, I'm having her next week. I had literally horrendous nodular cystic acne. And don't get me wrong, there are creams, like we can use azelaic acid, which we also use for rosacea. And we can use basic antibiotics, which really are not effective. And do you think I was going to throw them on top of my already vomiting body? No way I'd be able to tolerate them. So for me, it was pseudocreme, which is the absolute wrong thing to do. But when you are in agony and you're trying to take your makeup off and you're nearly crying because you've all these cysts, it kind of calmed it down. But what does it do? It blocks all the rest of the pores because it's oily based, and then I'll have another crowd of spots there the next day. I sent a picture to my sister because she was living in Australia at the time, of my lower face, and she's like, oh my God, you're a poor patient. I was like, why would I send you a picture of my patient? I was like, this is me. And she could not believe it. This is my face.
I'm sorry, I'm more confused. Sudocreme is just not to be put on spots.
No, we've all done it. I did it myself. I should have known better, but it was the only thing that gave me relief.
Yeah.
And I just couldn't tolerate anything else. As in, the vomiting was morning, noon and night. To try and do a proper skincare routine at nighttime, I was like, if I could just wash my face, that was about as much as I could get through. Dab on a bit of Sudocreme. Other people use toothpaste. Other people use alcohol, anything to try and dry it out.
Yeah.
And that kind of took the redness out of it. But like, I was just kind of blocking up the rest of my pores. So the minute I had my little girl, I was like, please, somebody fix me. Somebody give me Roaccutane. And I took a very low dose of Roaccutane over a longer period of time.
Okay.
Because I work in theatre, I'm in behind a mask. So obviously, like, we've all experienced masks for the last number of years. But when you're in theatre for hours at end and you're behind a mask, you can't take your mask off when your hands are scrubbed to put your lip balm on. And the most important thing is when you're on Roaccutane is having a lip balm in every handbag, every pocket that you own.
Serious amount of them when I was on it. Like you literally, and you know the way you go out without it, and
that's a disaster.
Horrendous.
Total, yeah.
I remember having to run in places to buy lip balm just because, but it's the lips and the eyes. But I managed to avert the eyes by just using the eye drops every day. Yeah. So it's amazing what it's great what you can do if you can preempt.
Yeah, and we would use, like, I print a patient information leaflet for all of my patients. It's very individualized to them, their body weight, their target over roughly somewhere between 6 to 8 months. The average Irish person will be on it. Like that's the thing when patients read on the internet and they read the side effect leaflet, it says the average course is 4 months. But I've never been able to get one of my patients off treatment in 4 months because we can't use those kind of doses. We've very fair skin. We're just much more sensitive in Ireland. Most of those studies were done based in the States and in the UK where they just have a darker skinned population. So we're not quite comparable. So I would always say to my patients, you're going to be on this for about 6 to 8 months. For me, I was on it over a year because I just stayed on low dose for longer and the outcome is still the same. But it is really important that you have 1 month clear of spots at the end and you've reached that target for body weight. That's the most important thing. So stick with it.
What I found the side effects that I had the most, I remember waking up one day and listen, I know what the side effects are anyway. I've given it out for so many years. But I remember waking up going, Jesus, I must be getting old. I'm very perimenopausal. My joints are so sore. Yeah. I had to give up yoga when I was on it because the aches and pains are very real, aren't they?
It can be. It's a funny one. It basically affects about 10 to 15% of people. Some of my teenagers are flying through it. They're doing 20 million sports and it doesn't take a feather out of them. And then I'll have like a 40-something-year-old female, like ourselves, and they're like, oh, I'm getting out of the chair. Like I have a few teachers and they're like, the students think I'm going granny phase, because I'm getting up out of the chair to go to the whiteboard. And I can't even get up. I had some lower back stiffness and I was only on low dose. And I had some dry lips, but basic because I was on the low dose. But other than that, flew through it and absolutely, like if I had to take it tomorrow, I'd be like straight back on it.
I loved it. It cleared up my skin because I had the hormonal acne that you're talking about, like good skin up until about 28 and then got the hormonal acne. But then I was reproducing several times, so I couldn't.
But then it's like every month it just becomes like, oh, here we go again. Like
I was never spot free by that stage because it was always either coming up or going down. But it was hard, and
it's really hard for women because like obviously, don't get me wrong, guys can get acne too, just the same as women, but we never seem to get that stability of our hormones. And 20 to 40% of women will still grumble into their 40s with this every month, like I'm getting more spots, this is driving me mad. And they're spending a fortune on skincare, they're doing really good skincare routines and it's still not effective enough. And then on and off the contraceptive pill or having babies, as you said, there's constant fluctuation in the hormones. Men, of course, they still can, but I would not have the same amount of patience as a 40-year-old man with acne the way I do having 30 and 40-year-old women. Of course.
And then menopausal acne as well, that kind of perimenopausal where your hormones are in flux.
And you can have a bit of both. Like we do see an awful lot of overlap between rosacea and acne, which we can use Roaccutane for both, and I do use it.
So again, rosacea can be cleared by Roaccutane as well?
Yeah, again, it's not a licensed indication, but as a dermatologist, I do lots of stuff that's off label and off license.
Oh, I know. You guys are devils.
Sending you in all those prescriptions.
You drive us crazy.
Yeah. But we're never going to go back and get a clinical trial on it, so it's never going to get a license. Yes, we do in low dose. So if somebody has done their topical therapies for rosacea, they've done their antibiotics and they're still flaring. And some people have really debilitating rosacea, like really, red, hot face, lots and lots of spots.
Sorry, can you explain what it is first?
Sorry, yeah. So rosacea is, again, it gets confused with acne, but the classical distribution is more central face. So it's your nose, your cheeks, sometimes the center of your forehead and the center of your chin. But when you look closely, there are no blackheads. So that's the differentiation between acne. So if you look, you do not have blocked pores. And thankfully, rosacea doesn't scar. Now, don't get me wrong, when you have an active flare of rosacea, rosacea, you feel like, oh my God, these spots are never going to go away. But you can get back to crystal clear skin after rosacea. Some people will have what we call the erythematotelangiectatic component, which are the red broken capillaries. Again, if you look close, you'll see like these tiny little like red and purpley veins or capillaries on the skin. And that can be treated really well with IPL or intense pulse light. But medically, we would use tetracycline antibiotics for their anti-inflammatory effect. My favorite cream is topical ivermectin.
It's fantastic, isn't it?
Absolutely, because I don't like using, dual topical antibiotics and oral antibiotics together. So some of my patients don't need oral antibiotics. If they're at the milder end of things, I'm just going to tweak their skincare routine, make sure their moisturizing and face wash has ceramides, make sure they have a proper sunscreen and just their topical cream at night. And they never need to go down the oral therapy route. But if patients have tried and failed, they've done their best with that, then I'm going to use low dose Roaccutane. And often somewhere between 4 to 6 months. They wouldn't necessarily need to be on it as long as an acne patient would. And again, they do better because they're on lower dose, so lower amount of side effects. So the dryness is a bit easier.
Yeah. And can GPs prescribe Roaccutane?
It's supposed to be prescribed by dermatologists. It doesn't mean some GPs don't, but it is supposed to be prescribed by dermatologists. Yeah.
Okay. Mm. So, but if a GP has done a special training or something like that, can they do it? Or is
they do. And I'm sure like if you felt comfortable with it, there's a lot of nuances and you kind of learn it as you go along as a dermatologist, as you know how to tweak the doses. And I do see people who've of course had Roaccutane elsewhere before, and they come in and saying like, there must be something else you can give me because I've done Roaccutane and it hasn't worked. I mean, Roaccutane has about a 75 to 80% success rate in that you take one course for your acne and never have to do it again. So it's incredibly successful versus oral antibiotics, which have about a 30% success rate. And they don't have a success rate at all for scarring acne. That's just for inflammatory acne without scars. But sometimes I see patients only on it for like low dose for 3 months. And yes, of course you start to turn the corner and my spots are gone. But then, 2 years later, they're all back again.
It literally has to switch off those...
shrink those oil glands right down. Yeah, keep them shrunk for a certain period of time. Otherwise, if you stop the course too quickly, they're just going to open back up and you're going to produce your oil again and then start building up the blackheads and then the whole cascade of the inflammatory spots happens. But the most important thing is if you have acne and you start to see it scarring, please give up your topicals, give up the oral antibiotics and get a referral to start on Roaccutane.
And can a 14-year-old go on Roaccutane?
Yeah, absolutely. I have lots of young patients on it. Okay. And there isn't an age limit per se. I've treated, babies and 2-year-olds with Roaccutane. Not commonly, thankfully, it's rare.
What is that? Is that's not the same as baby acne, these little things?
Yeah. So within the first kind of 6 weeks, you get that neonatal acne, which is all these little tiny spots. And my own little girl had it. I was like, Jesus, I had acne for like the 9 months of the pregnancy, and now she has it on her face.
I can't take a picture of her.
Yeah, exactly. I was like, but we'll be there putting on some concealer. So she absolutely, and it was like my hormones. So it's kind of that withdrawal of the maternal hormone. And so she had it up to 6 weeks and then I was absolutely fine. I just gently clean the face. You don't really normally need to treat it. But if you start to get it after that and you're getting it in the early months of infancy up to toddler, then it can scar you. You see some kids with these little ice pick scars. Yeah. It looks like somebody got like a little cocktail stick and just literally poked little holes. So I've treated a few. This is in the past. I don't manage pediatric dermatology anymore, just in case anyone's listening there and thinks that I do look after kids. I do see kids like 10, 11, with acne, but I don't manage small kids anymore. But I did in the past, when I was working in Temple Street and in Waterford, and we did use Roaccutane in those kids because they're scarring. Like you have to switch it off. And the kids that get that kind of bad acne at that early age is a sign that they may also get it again when they're teenagers. So you want to kind of make their parents aware to keep a close eye. And the first sign of them when they start hitting, 11, 12, 13, if they're starting to get spots again, straight back in because they may be the ones that need to do it again. But of course you can do it again. There's no limitation to how many times you can take it.
Okay. Yeah. And I did refer to you guys as unicorns.
Yeah.
The reason being is
my daughter would think that's great. She loves unicorns.
Just for instance, someone does get referred to someone like you or one of your colleagues for acne treatment. How long can they expect to wait?
Well, like technically I am closed to referrals at the moment until like 2024 because we're out the door, but I would never turn down a scarring acne. So my secretaries are some sort of like magicians in the background and basically they will always fit in a scarring acne within 4 to 6 weeks. Okay. I either stay after work or I start earlier. Okay. So usually I'm doing the school drop off at 8 o'clock and I'm in my office at 7 minutes past 8. So worst case scenario, I normally try and start at 8:30. I need to just like chill, sit in the chair for a minute, turn on the computer.
Have your black tea.
But if the girls And again, my practice manager is my sister, and she is very passionate about acne herself because she did Roaccutane too. And I think if you have that first-hand experience, you would when you see people, you're like, this is so good. We just need to get you seen. We need to get you sorted. So she will like text me and go, you're starting at 8:15. I hope there's no traffic. And I'll always have an extra patient in first thing in the morning. So we'll always make space for that because it's life-changing. Like literally life-changing. And don't get me wrong, we have incredible new lasers. They have evolved over time. We're having great results at the moment with our Secret Pro. We have that since last year. How did you get on?
Did you see my video?
Yes, yeah. Your favorite treatment, Laura.
Oh my goodness. So I couldn't take the second go of it, but I think my skin already is feeling amazing after it. I
did my eyes last week. No, like when did I? No, a week and a bit. Yeah. I love it. Yeah.
I got a little bit of PRP as well. I love the PRP now. I'm mad for it.
Straight after is into trying.
You just around
just to heal it up quicker. Get all those growth factors back in there.
I loved it. Yeah. So I love all that technology that's up and coming and new. Yeah. But definitely.
But our aim is that we never need to do that. Yes. If we could see people, and as you said, I mean, when you look at the studies, the average amount of days that a patient is on antibiotics before they ever get an opinion of whether they need their isotretinoin or not is just short of a year, 300 and something days. That's 300 and something days of antibiotics, which people shouldn't be getting.
Which they shouldn't be getting anyway. Yeah. And that's so interesting.
12 weeks is the kind of, should be the gold standard of care. And if they have not responded to that, then that's it. Like that's not going to work at month 4 or month 5 or month 6. So they shouldn't be getting anymore. But yes, we do have the dynamic duo of a combination of radiofrequency microneedling and a CO2 laser to really help with those acne scars. It's also for skin rejuvenation, for anti-aging. But and I'm having it because I have scars on my lower face, and it has definitely improved. Do I have enough time to ever do a proper course of anything? The answer is no. The girls have to drag me down into the cosmetic suite to try and get something done. We're just so busy with patients, and like they're like, we'll do it on your lunch break. I'm like, hold on a minute, my face will be falling off.
I know.
But I actually did do my eyes on my lunch break a week and a half ago, and I literally came upstairs and I was like, everyone's going to think I'm going on 10 rounds with a boxer. Like my eyes were really swollen and red, and then thankfully the redness went out quite quickly, but I put my mask back on and I kind of hide away a little bit because I kind of had red underneath my eyes. But the next day I woke up, and you know that feeling when your eyes are so swollen, they're like slits. And I just woke up in the bed going, oh my God, I have to do a clinic today. How am I going to go in? And I was there with the cold compresses, and the girls had given me the cryo sticks, and I was trying everything. I had to say it to my patients the next day in clinic. I was like, just so you know, I'm not having an allergic reaction. I have an allergy to fish. And when my little girl saw me next to me, she's like, Mama, did you eat fish? Because I literally was like that swollen. And then by day 3, I was a whole lot better. And by day 5, I was like perfect.
Well, I did it on the week that I launched my new products, and one of them is called, one of them is actually for skin. So I was like, this is really bad time, because I was going to cancel. I was like, this is really bad time, and like I'm literally going and I'm going to be on camera talking about a skin product that I
clearly don't take myself.
that clearly doesn't work. But anyway, I think everyone took it well. The only thing is that Katrina gave out to me for going out dressed as Wonder Woman for the women's mini marathon.
Sunshine,
but I did wear loads of SPF because I was
hiding away that weekend. In fairness, if I had anything on, like there's no way you could have gone to a formal event. Like, so do not be doing it in, a day before a wedding, or you're going to something important. Because I had my eyes done, so I didn't put on any eye makeup or anything. Like it was too puffy anyway. Like you'd look horrendous. Makeup on top would be worse. But hopefully worth it. So
Can I ask you just one thing about Roaccutane that people always worry about? Because a study did come out. Well, it wasn't a study as such. There was a big thing in the Daily Mail about Roaccutane can cause suicide, particularly in teens or something like that. Or can you give me your expert advice on that?
So Roaccutane is 41 years old this year, so it's been around a really long time. So obviously when it first started in the 80s, there were reports saying, as you just said, that Roaccutane can cause low mood, depression and anxiety. And then when that was teased out over time, what we realized is acne can cause low mood, depression and anxiety. And clearly that's what I see in my clinic, like every day of the week. I could Monday is my longest day. I work until 8 o'clock at night on a Monday, and I would potentially have 20, 25 people coming into me new with acne or already established on Roaccutane. That's how many people I would see just on a Monday. So really now having Roaccutane, I feel, is nearly as common as having braces as a teenager.
Yeah.
But yes, that is out there and we can't take it back. We literally can't take back those studies. But when they were some of them were very poorly designed studies, and obviously for women, they need to be put on the contraceptive pill at the same time. So you're ideally supposed to be established on some form of contraception a month before you would go on Roaccutane, have a negative pregnancy test, and then you can start on your Roaccutane. But any woman who's ever taken some form of hormonal therapy would tell you as well that that pill just didn't suit me. I was like a crazy person. One minute I was crying, the next minute I was cranky, so there was a lot of that as well in some of those studies. So there was a lot of other confounding factors. One of the biggest studies has just come out last year in the British Journal of Dermatology, and it's basically looked at different groups who were treated with acne over the previous 7 years, looking at millions of patients. And in a nutshell, they divided it into topical therapies, which is creams, antibiotics, the hormonal group, which was obviously for women only on hormonal contraception, and that would be the combined oral contraceptive pill, versus Roaccutane. And the group with the highest rate of anxiety and depression was the antibiotic treated group, and the group with the lowest rate was the Roaccutane treated group. So we would deem it to be an incredibly rare side effect. But I suppose the difficulty is the commonest age to get put on Roaccutane is in your mid to late teens into your early 20s. And that's also the age when mental health conditions can start to present themselves. So that's why it kind of can get really confusing. And of course, like if you're coming up to leave and so you have a lot of stress on your plate, that is like, it's often the worst time to have to manage your acne. But I would have plenty of patients who have known anxiety, known depression. They take anxiolytics or antidepressants. They're going to their psychiatrist. They might be going to their counsellor as well. And I would always write to their psychiatrist and say, I have this patient, they've very bad acne and I really want to put them on Roaccutane. Is there any contraindications to this? And I have yet to receive a letter from a psychiatrist telling me that I can't give it to any patient. Have I ever had to stop it? I haven't. And I know there are other dermatologists, of course they have. I have had to take temporary breaks, with patients because they might say, do you know what, like just this month my mood. And then you kind of tease it out. You're chatting to the teenagers, like, is there anything going on at school? Is there any? And like I've had one that there was bullying going on in school. There was something else, there was some problems at home. So there are often other situational reasons. And we take a temporary break. I mean, what everyone needs to know is it's technically gone out of your system in about 4 to 5 days. So worst case scenario, you feel that your mood has changed adversely, just stop it.
Yeah.
And then fingers crossed, everything's good a few days later. So there's never any harm in taking a break, and then you get other people ringing up going, oh my God, I missed a dose. Is my acne treatment going to be adversely affected? I'm like, it's okay. It's still in your bloodstream for a few days. If you missed one tablet, it's not the end of the world. Yeah. But some people are so invested in this is the time for them to do their Roaccutane and they're having such a good response. They think, oh my God, if I missed one pill,
you totally understand why.
Absolutely. Having done it myself, like if I thought I had done my course of treatment incorrectly, I'd be kicking myself. Yeah.
And can I ask you this now too, because a lot of people message in and, I hear it a lot. I'm sure you hear it a lot. People think that if they exclude dairy from their diet, that their acne will go or their eczema will go. Or, is diet, does it play a huge role in skin issues, be it either psoriasis or eczema or acne?
Yeah.
How important is it to, say, use an exclusion diet when it comes to skin conditions?
So it is important in some conditions and not so much in others. So if we start with acne, there are plenty of trials, really good trials showing that patients who have a high dairy intake, particularly actually more the skimmed milk as opposed to the full fat milk, they do get
high sugars.
Yeah, and you just think it's the opposite. You think, I'll cut out that fat. Those patients can trigger flares of their acne, but ultimately acne is genetic. So, when I see a patient, I'll be saying, is there anyone else? And often the parent sitting in front of me might have said, well, I actually had to take Roaccutane when I was 20, or uncle had very bad scarring acne. So what I would say, it's usually the teenage boys, because they're playing rugby, they're playing sports, and they're like, come in and it's a litre of milk to rehydrate. And I'm like, sorry, how many litres are you going through in a day? You see the trolley, somebody going around the supermarket with all these litres of milk. So if they're drinking way too much dairy, I will be getting to tone down on it. Whey protein supplementation has been shown to drive flares of your acne. So again, if they're working out in the gym, I'll get them to switch their protein supplement to either just eating healthily and taking in, more chicken and more eggs and things like that. But switching from whey to either a pure protein or a vegan protein, like a pea protein. Apparently it tastes disgusting. I have no clue because I don't drink any of them, but the boys tell me it's awful. But I'm like, well, that's
what protein stuff.
Yeah,
it doesn't sound great.
Not nice. No,
I've tried to use those protein supplements just to build
build muscle. Yeah,
you know?
yeah.
And I've yet to find one that I like the taste of.
See, I don't like anything kind of liquefied and sweet, and I would do anything to avoid getting a flare of my acne again, because having clear skin is like the best thing ever.
Yeah.
So I haven't tried them, but I would get them to stop the way, cut down on the dairy if they're drinking a lot. But if they're just having like, you know, a drop of milk in a cup of tea, and they might have one bowl of cereal. Exactly. That's not excessive milk. A high GI diet, like too many carbohydrates, too many kind of, you know, eating pizza every other day of the week, that absolutely, again, it's high glycemic index. You need to cut down on that. So any skin condition, when you have a healthier diet, when you have proper protein intake, plenty of fruit and vegetables, you know, mixture of color in your diet, is, of course, it's going to make your skin look better. There absolutely, with eczema, of course, there are people who have allergies. Now, it's much more common to see food allergy in children, you know, with severe eczema than it is in adults. But it's not always that they're eczema flares because it's a food allergy. But if you've got bad eczema on your face or around your mouth, and then you go and eat, you know, citrus fruit or tomato, it's more of an acidic food that it can cause redness, you know, around your mouth, just because it's more of an irritant to the dermatologist as opposed to an allergy. But a true allergy is often getting lip, tongue and throat swelling. So it's immediate. So I have a fish allergy. So like if I ate fish, my lip would start to swell. And that only happened to me in pregnancy. I mean, seriously, I had the worst pregnancy known to man. It all went horribly wrong. I was about like nearly 30 something weeks pregnant, barely able to start eating again, and like went out for my first dinner and ended up with like, you know, lip, tongue and throat swelling.
Was your allergy triggered by pregnancy, or had you been allergic before that?
No, it only happened in pregnancy. Yeah.
And now you can't touch fish?
No, I mean, I went and I actually, because I introduced it to my little girl. I mean, it's nice to give her a broad range of food. Yeah. And when she was small, I introduced it and I chopped up her dinner with my knife and fork. And, you know, I just didn't think, you know, you're busy. And I was like, and then I obviously then ate my own dinner with it, and a trace, like there wasn't actual that you could see fish on it, but there's a trace on it. And then within you know, a few minutes my lips started to swell, and I had antihistamines. So
doctors aren't infallible after all. You also commit
absolutely and get skin conditions. Even my dog had eczema, like typical dermatologist dog. Yeah. So, and my dog had one of the new JAK inhibitors for his bad eczema. Yeah. So the new drugs that are fabulous, new treatments. His option when he went to the vet was he could have cyclosporin, which, as you know, is heavy duty immunosuppression, or he could have a JAK inhibitor. And I was like, well, you know, I don't want him to have kidney damage from the cyclosporin because he's only a tiny little dog. I was like, I'll take a JAK, and he stopped scratching. Brilliant. And the clinical trial was done on 20 dogs, no blood tests taken, and they all did fine. So they are a new treatment that we have for lots of different things.
And we can use this for actual humans as well.
Humans now, which much more vigorous trials. We use it for alopecia, and we use it for atopic dermatitis. They're used in other specialties like rheumatoid arthritis and stuff as well. But there's loads of new drugs coming out in the last few years. It's brilliant. I mean, dermatology is really changing in the last.
It's so
10
exciting,
years.
isn't it?
It's fab. Like, I mean, it's nothing worse when you have a patient sitting in front of you and you're like, you know, the worst eczema, and they've lived with it their whole life, and you're like, okay, all I have for you is, you know, methotrexate, which, don't get me wrong, for some people works really, really well, and for others they feel fatigued, they feel miserable on it. Really not an ideal drug for women of childbearing age. You know, I really hate having to give it. And now we have all these new therapies, so it's great. We have more options. Like waving magic wand.
Absolutely. So with the diet, like on eczema and things like that, and psoriasis, can
psoriasis? No. I mean, with psoriasis, we know smoking and alcohol makes psoriasis worse, but not specific food groups. Rosacea, absolutely. It's not the cause of your rosacea, but alcohol can cause flushing for some patients, spicy food, hot tea or coffee, certain foods for certain patients. So
all the good stuff.
Yeah, exactly. But you have to balance out with your quality of life, you know. So if you know you're going to flush with alcohol, but it doesn't bother you, well, sure, have your few drinks, you know. But if you know you're going to go a bit red, it's not going to last forever. It'll calm down. So do it. But for some people, they do avoid it because it causes it every time. And for some, it's sometimes and not other times. But it's not that the food caused your rosacea. So again, you have to have the genetic predisposition. So again, curse of the Celts, fair-skinned Irish people. Yeah. And then something tips you over the edge. And I do see kind of rosacea coming out and you're saying like, could it be coincidence, but in women who've gone a bit kind of hell for leather with the skincare routine and they thought they were doing everything anti-aging and they went and bought loads of anti-aging products and they start kind of putting on alpha and beta hydroxy acids and full strength retinoid and full steam ahead, and all of a sudden they're like, rosacea. So they had an already slightly sensitive skin. Yeah. Someone in the family already had the high color and, a tendency to rosacea, and they just tipped their skin by impairing their skin barrier, tipped it over the edge, and then they're full blown rosacea. So you have to be careful. Yeah.
Absolutely. And people wondering, is there like, what do you take vitamins or anything like that for your skin? Do you take vitamin C, or is it just the topical stuff that you use?
I take vitamin D every day because I'm never going to get enough sunshine, like ever.
Well, you go around covered up completely.
Basically, yeah, totally covered, hat, glasses, full length clothes. So I take vitamin D every day, and I have been vitamin D deficient many times. But that's not just because I avoid the sun. I actually had a virus when I was a teenager during my junior cert mocks, and I never went back to school until I did the junior cert. So I was off for 4 months. Okay. And after that, it was a bit like, poor people with long COVID. So it just put all of my hormones out of sync. Okay. And I had an abnormality of my parathyroid hormone, which serves for proper vitamin D function and metabolism. And I literally had negligible amount of vitamin D, which I didn't know about for a long time. So then I found out in my early 20s, I had osteopenia. So I have always been on supplementation. So even without being, because I wasn't a dermatologist at that point, I have been on vitamin D before that. Okay. And then obviously now avoiding the sun. So I've been on vitamin D for like 20 something years. So I take...
Before it was cool to take vitamin D?
Before it was cool, I was, trendsetter. I have been on 25 micrograms and occasionally I boost it with Altavita. Like I take... 10,000 international units.
Oh yeah, just lob it in there.
Yeah, absolutely. And then I take Caltrate on the days that I am poor with my calcium intake. Yeah. I have to take it all the time. And actually I'm keeping on top of my own medical health recently. Not every year, but I had another DEXA and everything is stable. Because it is normally progressive. So you keep on top of it. So I do take that. I take vitamin C and zinc every day. And I do that for like, not just skin, but I just feel I am exposed to so many people all winter long, people coughing up a lung in the clinic every day, and small kids bringing in bugs. So I take vitamin C and zinc, and I've been behind an FFP2 or an N95 mask, and I still wear it in the clinic even though the rules have changed. I chat away to people, and then when I'm going to go up close and examine, I still put it on because there were so many other bugs in the last few months that everyone was suffering with. So touch wood, I just kind of try and keep the bugs away, because if I get sick, there's no one else to do my job. I'd have to cancel a full clinic of patients, and then patients are like, where are you going to put me? And I'm like, I don't know, I've nowhere to put you. I have no empty clinics. So it's trying to stay healthy and say I take folic acid every day. What else do I take? That's my 3. And I take starflower oil evening primmer as well. Okay.
And is there anything is there studies that suggest that taking an actual collagen supplement works? Because like there's loads of them in the market.
There's loads, and they are expensive. Yeah. It's almost like buying another cup of coffee a day. There's so many. I mean, because they've been around for quite a while. Yeah. It's more the hydrolyzed collagen that there are studies showing that they can be of benefit. I haven't started it yet, but I'd only read something recently on it. So that's my next thing I'll probably add into the mix. I'll be there 10 hours later in the morning. But your new vitamin, it will give me all of my vitamins in one. That wasn't where
I was going with it.
But that is like literally I will be able to condense it all into...
I might be able to give you a freebie after today.
Literally, how many do I have to take? 4 separate things. I can have them in one. But they are the vitamins that I take for my general health.
Yeah, because people always kind of want to know, is there anything that they should be taking? So we've done the nutrition and whether or not it affects skin, and we've done if people can take supplements. So what I wanted to go on to now was hair loss. Yeah. Because people don't actually realize that dermatologists look after hair loss.
Hair, skin and nails. Yeah. So it's all three.
And it's also to do with the fact that your hair grows out of your scalp, and your scalp is your skin too. Yeah. So it makes sense. Yeah. Mm-hmm. So can we discuss the different types of hair loss? I know it's like how long is a piece of string. Yes. But maybe like what can you do for people that are suffering from hair loss?
So there, as you said, there's lots of different types of hair loss. I suppose the commonest that we would see would be, it's either a mixture, it depends on age, but there's the non-scarring alopecia, and then there is the scarring alopecias. So women in general suffer more with the kind of scarring type alopecia. So that is frontal fibrosing alopecia, where women will come in and say that, my hairdresser actually is usually the first person to notice it. My hairdresser is saying that I'm, starting to go thin and my hair is going backwards. And then if you have a closer look, you'll see that they have some inflammation or redness and scaling around each of their hair follicles. And if you look, their wrinkles will kind of stop. It's as if it's 3/4 way up their forehead. And then they have this lovely, smooth, white, shiny skin, which used to be covered with hair, so it didn't get sun damage, and now their hair has gone back an inch or an inch and a half, and it's usually from ear to ear, so it goes the whole way around. So that's common around. Often we see that around perimenopause, menopause, and it can happen at any age, but it's more common at that age. And there are links with genetics. I have some twins with it, and some sisters with it, or my mom before me had it. We don't know the exact cause of it, but because there is this link between possibly, the chemicals that are used in sunscreens, or the chemicals that are used in moisturizers with sunscreens. And there is some data on it, but it's not set in stone, because if you look back in novels that were written like in 1800, there's documentation of, the housekeeper had, hair that was going back to here. So it has to predate sunscreens being developed. Okay. But what I would normally say to my patients is put your sunscreen on, obviously up as far as here, but don't be rubbing it into the root of your hair follicle if you're suffering from this condition. What we can do about it is we can kind of target it from multiple ways with anti-inflammatory therapy. So if it's really inflamed, I'm going to inject it with intralesional steroid injections. We then often use avoiding kind of topical steroids long term, because there's not a cure for this condition. It's about maintenance. So then instead of just using topical steroid all the time, we use topical tacrolimus, which is kind of immunomodulating, and the person would put it from ear to ear, the first 2 inches of their hairline backwards. And we use... Is it
autoimmune then? Is it
kind of on a spectrum. Yeah. Okay. And often patients, they might have thyroid disease that goes with it and things like that. So, but definitely women, way more common. I can remember all of my male patients with it. Do you mean on one hand versus all of the women who suffer with it?
And if it is autoimmune, and so is it attacking the hair follicle with using therapy? Can the hair grow back, or just you're stopping it getting worse?
We can't give them back the hair that they had before this, 1 inch went backwards, because if you look, the skin is completely smooth. So those hair follicles have been destroyed. You can't see them anymore. They're gone. So we can just halt it in its tracks and maintain the hair that they currently have. But a lot of women will have adapted a hairstyle so that they might, put in a fringe or something like that. Okay. But, are very happy to make sure that the hair stops here and not keep going back. But it often could go back to a kind of where a hairband would sit,
Goodness.
So yeah, and it's really hair loss is really debilitating. It's again, terrible. The sooner we catch that, the better. And sometimes your eyebrows go first. So often people feel, oh, maybe I just overplucked my eyebrows, 20 years ago. But often they'll see that their eyebrows started to go first in the 2 or 3 years before they notice their hair. And it's often the hairdresser will say, did you notice that your hair was getting a bit kind of thin at the front? So that's one. Androgenic alopecia, or female pattern hair loss, or male pattern hair loss is incredibly common. 50% of men by the time they're 50 would have significant thinning, on the top and on the front. Versus women, it happens a little bit later. So again, similar percentages, but by the time we're 60, we would notice that our hair is getting thin. But the problem for women with female pattern hair loss, it's more of a global, diffuse kind of hair loss. So their hair is thin everywhere, as opposed to the way men are more just on top. Yeah. So most women have that kind of, it's kind of like the monk-like effect with the hair around the back and smooth on top. But again, we cannot grow back the hair, because what will happen is those hair follicles just become more miniaturized until they're gone. And once that hair follicle is gone, we can't open it back up. So again, the earlier you start treatment for that, you can maintain what you currently have.
And what is the treatment then?
So if the person is premenopausal, we would use a medication called spironolactone, which we also use for acne. And if the person is postmenopausal, we would use finasteride. And that's what men would get, but just in a different dose. So men kind of get the 1 milligram dose and women get 2.5 to 5 milligram dose. We also use minoxidil in the foam version to start off with. So 5%. I don't use 2% for any of my female patients, even though if you go to the pharmacy, you'll say you have to, and it just doesn't work. So it's always the 5%. And I prefer the foam than the liquid, just because it doesn't roll down onto your face as easily, and it seems to irritate people a little bit less. I'd often use...
it's heavy duty treatment though, the Rogaine, isn't it? Because you need to use it every single day.
Absolutely. No, we do use the oral version, but some people are great. They're so committed, they're so into treatment, and they will use it regularly. But a lot of the failure of topical minoxidil is just lack of compliance.
Yeah.
Like, could I honestly, on top of the whole skincare that I do every night, could I honestly then put topical minoxidil to my whole scalp every night? Probably no. I'd want the oral version. So the oral version, when you look at clinical studies over 12 months, it's not that it's a better treatment, in that if somebody used their topical minoxidil every day and somebody took their oral minoxidil every day, they'd still have the same hair count at 12 months, but the oral minoxidil certainly works quicker. So if somebody has telogen effluvium, which is a hair shedding, so you look in the shower and you're like, oh my God, my hair's falling out. You go to the sink and clumps of your hair coming out. That's often after pregnancy, a severe illness, a big surgery. We saw so much of it during COVID. Like literally a few months after having COVID, people were like, oh my God, my hair is like all over the floor. That is a recoverable type of hair loss for the most part, but there's nothing more stressful than seeing your hair coming out in front of you. So if you did nothing, it will gradually come back. But yes, if somebody's really shedding actively, then we can use oral minoxidil to kind of switch off that and switch the hair into growth phase rather than shedding phase. So pregnancy is great for most people. They look kind of glowy. Their hair is all thick, and except me. Actually, like literally in the last week, I looked incredible because I have really low blood pressure. And then it normalized for last week. So I was like glowy, like, because I was full of energy, and I was actually having a baby a few days later, and everyone's like, you look amazing. And I didn't even have like a baby bonus. I got a week, and then it was all went. And even the day after I had her, I remember the nurses checking the blood pressure and going, oh my God, like, we have to check you. Like, are you bleeding? Because my blood pressure had like plummeted. And I was like, no, that's just me.
I have really low blood pressure. Yeah. Do you ever get like kind of feel faint when you kind of stand up really quickly? Do you have?
Yeah, I take midodrine, which is a medication, as you would know, to try and keep me upright. So I've been on that since my 20s because I have probably fainted.
What don't you have wrong with you?
all since that virus when I was, so everything just went pear-shaped.
That wasn't glandular fever, was it?
It wasn't proven. I had all the bloods, but I did go like yellow, like Simpson's yellow with like, splenomegaly, hepatomegaly. So it had to be something like glandular fever. The fatigue and everything went with it. But the test was negative for sure. No test is completely perfect at the time. But yeah, I had really low, and I was incredibly fit, played a lot of sports. So they all put it down to that initially. And then like every time I go to like, you're going to grow out of this because you're just going to get old and you're going to get blood pressure and get arteriosclerosis and it'll be fine. And I still have like a blood pressure of like 85 on.
That's great. You've loads 60. To work with then. You could just go really unhealthy and you could still probably be below. Someone said,
why don't you just take up smoking and drinking and eat loads of, junk food and I'll be fine. It's great, except when you get sick, like if you get a temperature and you peripherally dilate, you just keel over. So fainting is like part of my life, but I obviously recognize the signs, but the midodrine has been really helpful for me. And I've been on that for years. I was on fludrocortisone, as you know, again, another type of way to keep your blood, and that just didn't suit me because I had low potassium all of the time, which is very dangerous for your heart. So I was having blood tests all the time. So that did not work. So I take midodrine. I take it twice a day, every day. And if I'm sick, I double the dose. And that literally keeps me with, a blood pressure of 95 over something. So still incredibly low blood pressure, but enough to make me not feel like I want to keel over. But if I stood up really quickly, I'm going to get that lightheadedness.
Yeah, I get that.
Yeah.
I get that.
So I'm always with my older patients saying, don't jump above the bed too quickly. Especially if I'm doing a skin cancer surgery and they've been lying down for like 20 minutes and then they go to sit up. I'm like, no, you need to take your time. Yeah.
Yeah, people don't realize it either. Sure.
No, and they've been a bit stressed and you've just given them like local anesthetic with adrenaline and stuff and they just feel a bit. So yeah, slowly. In the morning time, I'm like granny getting out of the bed, slowly stand up.
One foot after the other.
Yeah.
On the female pattern hair loss, post-menopausal, which is when it tends to happen.
Yeah.
On a scale, like a lot of women, it happens a lot of women. Is there anything that the average woman can do to help it? But, that doesn't really...
She can start with the topical minoxidil. Like you can just buy that over the counter, you can use Nizoral shampoo or like ketoconazole shampoo. Like obviously not every day, but even like 2 or 3 times a week. Studies have shown that it has anti-androgen effects. So I mean, by itself, if somebody has bad androgenic alopecia, it's not going to make a huge difference. But I would often add that in to the topical minoxidil because sometimes you can get a bit scaly in your scalp if you're using topical solutions. So they're getting a benefit of the anti-androgen effect and helping the scaling of using the topical solution. So that's the only thing you can do without seeing a doctor because everything else is on prescription. You can do PRP, which is platelet-rich plasma.
Is it good for that?
Yeah, it's not for every hair loss. Now, it doesn't work for the scarring alopecias. So, if somebody thinks, I have frontal fibrosing alopecia or I have lupus-induced alopecia, it doesn't work for that because your hair follicle is scarred. Yeah. But once you still have your hair follicles, we can do PRP. So often patients who want a kind of a natural approach to things and they don't like the idea of tablets will do that. So you would do 2 sessions of PRP and then you might maintain it once a year or every 18 months. And a lot of hair transplant patients will do that as well, where they've had their transplant and then they want to maintain it, because just because a man has a hair transplant doesn't mean his male pattern hair loss is cured. The process is, his genetic makeup is still there. So that new hair is going to be subject to the same hormones, and that hair transplant over time will more than likely start to go thinner again. So often they will be on still sometimes minoxidil, finasteride, and they might do PRP once a year. To maintain that. So,
and do women get those transplants as well?
They do, but they're just not as successful. Unfortunately, yeah.
And why is that? Do you know?
I don't honestly know because I don't do the hair transplant surgery, but it's like from just reading all the literature, it just isn't as successful. But I don't honestly know the answer to that. So don't get me wrong, I send my patients for opinion to get hair transplant. But if they have a scarring alopecia, they will not possibly even transplant them for at least 3 years of inactive disease. So you have to have them medically treated, that you've been taking regular measurements to have this kind of objective measurement that their hairline is stable and that there's been no further redness or scaling. And then they might consider that their condition is switched off. Like the condition can burn itself out, but what you don't want is that you sit by and watch it and do nothing until it burns itself out, because that hair loss is progressive. And then there's alopecia areata, which is often younger people. It can of course happen at any age, but that's an acute alopecia where somebody, again, sometimes the hairdresser is doing your hair and it's a smooth, almost circular patch of hair loss. So it looks like there's no hair follicles, but when you look closely, you can see the tiny hair follicles. And when we use our dermatoscope, which is basically our magnifying lens that a dermatologist would use, you see these tiny little exclamation mark hairs as a sign of activity of alopecia areata. And you often see this fine, fuzzy, baby white kind of hair coming back. And then we inject them with intralesional steroid to try and switch off that inflammation, which is like an autoimmune attack on your hair follicles. We're trying to dampen down that attack. And then the patient would use topical, like a topical Dermavate or clobetasone propionate scalp application. And then 8 weeks later, we'd bring them back and we'd possibly re-inject. And if you kind of catch them early, for the most part, patients can, regrow their hair. Now, you could also do nothing and it could regrow, so it's hard to know, but most people don't want to hang around and wait to see what would happen. So we would do that. So I could see a patient 1 year and I might not see them for 10 years. And then they ring up and say, God, I was with you, 10 years ago and I had some alopecia and I found a new patch, and we just inject it again. Now, again, we do have lots of medication. It's a lot of immunosuppression. So we would hit it hard with oral steroids often for the first 6 weeks. If it's actively like really losing it very quickly, like, 40-50% of your scalp hair is gone within a matter of weeks, we would use oral steroids. And then we use systemic oral therapies. And now we have baricitinib and new treatments. We had tofacitinib, which was not licensed for it. It was licensed for rheumatoid arthritis, but in the studies, people start to grow their hair. So we did use that before. We now have baricitinib, which is a drug that we can use for alopecia areata. Now, it's not just for one patch of alopecia. It would be for patients with significant percentage of hair loss or, general hair loss.
And can alopecia areata be caused by stress, or is it?
Yeah, I mean, some people will describe a stressful event in their life. But again, some people were like, my life was ticking along, everything's grand. Like I have no reason for this to happen. But it is more common in patients who genetically either come from a family where there has been previous alopecia areata or atopic dermatitis. So that atopic triad of asthma, eczema, hay fever, or they had, bad eczema as a child and then they go on to get alopecia areata. So some patients are more prone to it. So I would have patients who have eczema, alopecia and vitiligo, which is again attack on your pigment cells, and you start to get paler white skin where you lose your pigment. So I have some patients who have all of them. So it's just very autoimmune type of a person. Yeah.
You've mentioned pigment. So I want to talk about pigmentation and skin tags.
Yeah.
So the floor is yours, Nikki. Why do people get pigmentation? So how can they prevent it?
Yeah, I mean, most commonly it's women who come seeking help for pigmentation, and often women will see it during pregnancy, where they see, it's like you call it the pregnancy mask or melasma or cloasma. It has kind of two names, where they see pigmentation along their cheekbone or above their upper lip. And as the summer goes on, sometimes patients will say, God, by the end of August, September, my pigmentation is really bad, because they are being obviously exposed to the sun. So things can look not so bad in the winter and then look worse after the end of the summer. So it can be contributed by the contraceptive pill for some people, pregnancy hormones. So ideally, if you're going to treat it, because if you go on and have another pregnancy, it can just come back again. So if you really want to treat it, the best time to do it is if your family is complete. Kind of way. Otherwise, you might be going back on the pill, or you might be going on to have the same hormones again, a pregnancy. We would use a tinted physical or mineral sunscreen every morning forever, because if you do the treatment and you give up on it, the pigment will just come back. So it's a maintenance therapy. You use retinoid at night because retinoids help every other topical ingredient get into the skin more easily. And we would use hydroquinone, which is like a bleaching cream, 4% morning and evening. So it's kind of a full-on skincare routine. But I mean, I obviously use sunscreen every morning. I use retinoid every night. Once you get into the habit of it, it's quite easy. And you're not using hydroquinone for the most part on the whole face. Most people, it's patches of the face that would have pigmentation. But that's melasma. That's that classic either, pregnancy-induced females. Pigmentation is just a broad term. Like some people are talking about the brown spots on their face.
Yeah.
Which are just kind of the age-related sunspots. Solar lentigos or sun-induced freckles is the proper name for it. But that's often down the side of your face. And again, we probably just didn't put our sunscreen on. One part of our face gets it and we don't put it right out to the side. Irish people for sure on the right side get a lot more damage, more broken capillaries, more pigmentation, because we drive on that side of the road and the sun is constantly coming through, UVA is coming through the window. So we get more damage here. But that can be really nicely treated with IPL, intense pulse light. So it's pretty much a lunchtime procedure because you're in and out in about 30 minutes. It feels like an elastic band being kind of flicked at the skin, and you have sunscreen put on your face and then you go straight back to work. So we have probably similar amount of men and women having that, because a lot of men suffer with rosacea too, and they would do it for their broken capillaries. As I said, a lot of women, they might choose to wear makeup to cover things up, and men don't do that for the most part. So especially with Zoom and Teams and during the pandemic, people were looking back at themselves the whole time, and men were coming in saying, God, I look like I'm kind of permanently embarrassed or permanently flushed. When if you're in a hot room and you've got loads of broken capillaries, you're going to go red. And they were looking back at themselves, you know what I mean? So we'd have a lot of men who have IPL. It's a great treatment. Yeah. Like everyone looks better with IPL. And the beauty of it is most anti-aging treatments and aesthetic treatments take a while to see the benefit, because if you're trying to stimulate collagen, it's going to take months. Whereas even with one session of IPL, if you've got a decent amount of broken capillaries, you're going to look better after one session. Yeah. So it's kind of an instantaneous gratification from treatment.
And the thing about pigment treatment is if you do it and you go out into the sun for even like 5 minutes.
Yes. Yeah.
And you've got your pigment under control, you go out for 5 minutes, you expose your skin to the sun, and it can literally come back within 24 hours.
Like click your fingers.
So you need some factor protection for the rest of your life.
For the rest of your life, and ideally like sunglasses on a hat. Like when I'm on holidays now, I actually got this fab bucket hat. Caroline Donnelly in Duns the other day, and literally it's down to here. Like I couldn't walk with it on because I just crashed into everyone. But when I'm at the pool and I'm going to read a book, I will literally be covered down to like literally almost my jawline. So trendy, kind of cool. For most Irish people, they don't think it. They're like, sorry, you wear a hat. But I did have pigmentation before and now I don't. And I wanted to stay that way. I've gone through the hardship of doing all the treatment and now I want to keep it that way. So always a tinted sunscreen, always my retinoid and my hat and glasses.
I always wear a fedora. I always wear a hat. And for the...
Well, you're known for your hat, but you're probably the only person who can carry off that like cool hat. But my patients look at me when I say like, I have lots of patients, men in particular with, serious male pattern hair loss, follicularly challenged on the top of their head. I've taken off a skin cancer and I'm like, you have to wear your hat. I just don't like wearing hats. They're not cool. Yeah. Whereas if you're over in Australia and somebody saw you without the hat, they'd be like, why aren't you wearing your hat? Yeah. Whereas here, it's just not cool. Like I am the only mom on the side of the GA pitch, like with my hat on the cloudy day in the middle of summer. And even the coaches, I'm looking at them and I'm like, you're standing out there training the kids for like an hour and a half with no hat on. So I have the hat on.
And hats are an inexpensive way to
style of clothing, the most inexpensive way. Yeah, 100%. Absolutely. Yeah. So I always have my hat on.
Can you remove your own skin tags by using a
piece of thread?
A piece of thread.
Technically, you could. You're cutting off the blood supply at the base, but you could also run the risk of infection because that's going to take a while to fall off. Like it's really going to take that kind of 21 to 28 days. So you could get a wound infection. Now, if it's a tiny skin tag, chances are it's not going to be a massive wound infection, but there are easier ways to do it. So we use cryotherapy, which is the freezing treatment with liquid nitrogen for the smaller ones. And if they have a kind of a wider base, so they're not sticking out like on a little stalk, we would do snip excision. So I'd have lots of people come in. I give them tiny doses of local anesthetic. It's just like a bee sting for a second. And then I just snip them all off. They don't even have a scar because it's just like a little dot.
They're just like a little aging thing, aren't they?
Yeah, they can happen at any age. They like frictional sites. So anywhere that's going to rub, like around the neck, under the arms, into the groin crease, really common in essentially frictional sites. And if people get a little bit heavier, they have a tendency, because they have their skin surface rubbing off each other. So they may be more prone to skin tags. But they're an easy fix. But if you're going to freeze them and they are on a sun exposed site like your neck, the best time of year to do it is in the winter time. So I'd often say to my patients, if they're with me there in the summer and they want them all gone, I'm like, well, are you going to be out in the sun all the time, whatever? Because there's a little bit of staining after doing the freezing treatment. So you're better off not getting any more sunshine on that because it'll prolong the staining. So we just do it in winter when everyone's wearing, polo necks and scarves and stuff like that. So so it often come back in winter just for that. Now, anywhere else in the body, you can do it. But if they've a lot, like some people could have, 100 tiny ones on their neck, I'd normally do in the winter time.
Hirsutism.
Yeah.
So a lot of people asking about how do they get rid of hair on their face? I think a lot of it could be hormonal.
Yeah.
Is microblading or dermaplaning a good idea, or will it just grow back?
Yeah, I mean, the problem with hirsutism, it is a maintenance treatment, and often we would see it in patients who suffer with PCOS or polycystic ovarian syndrome, and you can do all the treatments, but it will still come back. So it is a maintenance treatment. Dermaplaning is more for the peach fuzz, as we call it, that almost kind of see-through hair. So whereas hirsutism is the terminal hair, it's the dark hair that you'd see on the jawline or on the chin. I mean, you can scratch off with the dermaplane that type of hair, but it's coarse hair, so it might be a little bit more irritating to the skin. Whereas the dermaplaning gives you that glowy look. If you have that peach fuzz that comes down the side of your face, particularly when you become perimenopausal and menopausal, women start to see like.
Did you point at me for a reason there?
We're that age. We're that age. So it's only a matter of time.
No, I'm seeing more hair on my face and long.
When the light comes across, you're like, oh,
my brother, I was at a GA match the other day. The whole family went down for one of my sons had a hurling match. And my brother turns around to me and goes, you have a big long black hair there growing out of your chin. Can I pull it out, please? I was like, tweezer, pull it. Yeah. No, he wanted to do it there and then with his nails.
No, that would be But you can use creams. You can use bleaching creams.
Yeah.
Vanica is one of the creams that we use. But again, it's a maintenance treatment. Yeah. And you can have laser hair removal. But again, it's not a cure. So you do a course of treatment, but you still have to maintain it.
And the laser won't get rid of the peach fuzz either, though.
No, the laser doesn't do the peach fuzz.
It's only for darker hair.
Yeah, it's for the kind of the darker terminal hair.
So you either put up with the peach fuzz or
dermaplane the peach fuzz, or you do laser IPL essentially for the darker hair growths, which is more common down the sides of your face, chin and jawline.
Okay. Yeah. Can we talk a little bit about anti-aging treatments? I did a lot of it with your colleague, Katrina, nearly a year ago now. But the neck, which is often an area that we forget about.
Yeah.
But then suddenly you look in the mirror and you've got a very old looking neck. How can we help with our neck? Because it's a funny area too in terms of...
it's very sensitive.
Yeah.
The problem is it's one of the hardest areas to treat, and we're all really good with our skincare, put on your face every night, and then we forget to extend it down onto our neck and our décolletage and the backs of our hands, putting our sunscreen on. So the biggest giveaway really of your age actually is your neck and back of the hands, because even with anti-aging treatments, people are often coming in more frequently to concentrate on their face, but they're not doing anything for their neck. So you kind of have this mismatch between either the top half of your face and the bottom half of your neck. Yeah. So you look really young up here, and then everything's starting to sag down here. So I mean, it depends on what is bothering that you want to do, but using your topical retinoid down onto your neck, using your sunscreen down onto your neck is what you can do topically. But again, like starting them on your face, you have to treat your neck as being very sensitive. So you don't just whack on a load of full strength topical retinoid and think that you're not going to have dermatitis on your neck a day or two later. So you have to slowly introduce it there. You can do Botox or botulinum toxin injections into your neck. So we can do it for the rings that go across our neck. And when we all get older and you kind of go like this, you can see the muscle kind of bands sticking out. We can relax them as well, because they actually pull on your lower face, pulling it down. Okay. So that can relax the pull on the lower face as well. So you can do that. We can use skin boosters like Profilo. which would be one of the commonest ones, where you're injecting pure non-cross-linked hyaluronic acid to kind of plump the skin. So again,
Profilo. I wanted to ask you about that. What are your thoughts on Profilo? Because some people get on well with it, and then some people don't.
Yeah, I think it's a lovely treatment for people who are a little bit afraid of, totally going down the route of aesthetics and thinking, God, something could go wrong. It's mainly we use it from the outer aspect of your eye down. So it's not injected up here. So this is more your anti-wrinkle injections up here. So it's from here down. It's injected in 5 points on each cheek, and if you're going to do it down onto your neck, it would be 10 points. And again, you can use it on other body parts as well, but it would be 10 points on those body parts. It doesn't take long, and it's not that sore. For anyone who's had an anti-wrinkle injection, again, that feels like a kind of a bee sting going in. This is a much slower injection, so each injection's over about 30 seconds. So you feel tiny needle for a second, and then you don't feel anything. It's like more like a little bit of pressure. And then the downtime, for the most part, is only like 1 to 2 hours, where you kind of get a little bee sting type of a swelling at the site. And I've had it done once. I didn't even, it's supposed to be 2 sessions. I've done one. Like I'm like the worst. I don't practice what I preach.
Okay.
I've done one, and I went to collect my little girl from school straight afterwards, and I didn't even have a bump by the time I drove from Ballsbridge into the city centre. We normally say to patients the bumps could be there for about up to 24 hours, but most people it's gone within a couple of hours. And of course, any needle could give you a tiny bruise, but again, that's rare that would happen. And it just makes that skin a little bit more glowy. Now, it's not a filler in the sense of if somebody's coming in saying, I think my cheeks have fallen and I want to have my cheeks up here. I want my jawline. It's not that instantaneous where you walk out the door and once the filler has been put in place, you can see your new cheeks or you can see your new jawline. It's a skin booster. So it's not the same. But some people are obviously afraid of filler because there are potential complications, but you don't see that with Profilo.
Okay.
So it's a lot of people would do their anti-wrinkle injections and then they would do their Profilo for the lower face.
Okay.
So and then do it together.
For the neck, can you put filler at the top of the jaw to pull the neck up?
You can, you can anchor it down onto bone.
I'm great. I'm nearly a dermatologist.
Absolutely. You can do lots of things. You can between using a high intensity ultrasound, using we use Exilus 360, again, combination therapy. You can do lots of things to your neck and to your jawline, but there comes a point where somebody comes in and they're saying like, I want to do all these things. And if you're looking at them and they have done nothing anti-aging and they're like, 60 or 70 and the neck is really hanging down, there's nothing as good as a neck lift. Okay. So I'll be very honest with my patients saying, look, you're just not going to see the benefit with this treatment because there is a time to start these things. And if somebody has a significant, if you might have lost a lot of weight and there's a lot of kind of excessive skin and stuff, they just need to have that tightened up.
Okay.
So you can have a neck lift. So it's not a full facelift necessarily. There are newer, kind of less invasive ways to do neck lifts, but they're done by plastic surgeons. They're not done for the most part in Ireland by dermatologists. That would be plastics. So I would often refer my patients on. And then the eyes, that's another area that people really want to fix. And again, if it's really, a lot of people have genetic hooding, so where they really feel that top eyelid is nearly sitting on their eyelashes. And again, it can be really hard for them to see out. They feel like they're permanently tired and you can get kind of irritation with your eyelashes. If it's really, really bad, that would be blepharoplasty. So you'd go to the plastic surgeon and have a little incision done. Like there's no scar left. They can do it from the inside and they would take away the excessive fat, tighten up the skin. And then people look literally like 10 years younger. It's one of my favorite procedures to see done. Definitely a bit of bruising, but for about a week and then you're back to normal. Okay. And you literally look like your eyes are wide open again. You're fully awake. But we do use CO2 laser and radio frequency microneedling. So for the person who doesn't want the blade and they might not need it because they're just trying to make things look better and prevent it because it's radio frequency microneedling is stimulating collagen. So everything you can do to stimulate collagen to prevent further aging, which is what I had done last week. So yes, you're going to get swelling, you're going to get puffy, you're going to get red. But I mean, as I said, 5 days and I'm back to normal. Yeah. But a lot of people, we would give painkillers to our patients if they obviously need them for that procedure. We do put a numbing cream on as well. But I was in the middle of clinic. I put my numbing cream on for 7 minutes, not 20 minutes. And I didn't take any painkillers or Valium, which some people take. I didn't take anything. But I have a high pain tolerance.
But sure, like you, I turned up to the clinic. I read the instructions afterwards. You should put this on an hour before turning up to clinic.
You're like, is this enough?
I was rubbing it in before.
So, but we do treat you with painkillers and Valium if you obviously are nervous about it and things like that. And then of course you couldn't drive your car straight away for that. But not every treatment involves any painkillers. That's just the more intensive ones. So I'm trying to prevent blepharoplasty. So that's why I am doing the treatment. But I would never, I really, like, don't get me wrong, plastic surgery for some people, but not for me. I don't feel like altering my body in any other way. I'm just going to have to grow old gracefully. But if I do like to wear eye makeup, you see me all the time. I like to have my makeup on. If my eyelids start to go that way, I would definitely consider a blepharoplasty. That's the one thing.
Even you describing that blepharoplasty, I am eye phobic. Okay. So like that to me is absolutely. Because
they do it in the chair. Like a lot of people have it done under local with a bit of sedation.
But sure, in the pharmacy, the girls used to, anytime someone would come out with a sticky eye, they knew I was literally like, I'd look at anything, at abscess, I'd look at genitals, anything. When it came to the eye, but they do it. Laura, someone here.
I think we all have a thing. I don't like feet. Like it's just, so I don't like, it's even the thoughts of like a nail biopsy just kind of sends me over the edge.
Okay.
Yeah, so I don't.
We all have something, don't we?
Absolutely,
it's so funny.
Yeah.
Speaking about nails, actually, just quickly before because I want to ask you about how you got into medicine. Fungal nail infections are feckin' buggers to treat.
Yes.
And actually, I was just reading up on it recently, and the way the topical treatments like the Loceral
lacquer,
they say to treat the top of the nail, but the fungal infection grows from underneath the nail. So should people be digging it in underneath the nail too? So
the Loceral, like in my hands anyway, the Loceral lacquer is really only going to work in, the patient who has that superficial fungal infection where it's like white on the surface. I've only had success with Loceral lacquer and superficial fungus. Once the nail is thickened and yellow and you feel like you could scrape away all that debris underneath, that's when normally it's oral therapy with oral terbinafine that we would use, or itraconazole. But that is not without its complications.
No.
And if I have a patient sitting in front of me and they're on 10 other medications and they've had liver problems, or, and they might be older, I'm like, this is just like, we can live with the fungal toenails. We do not want to set somebody's liver over the edge. So you can use a very strong, like if it was one big toenail, for example, and the person's really bothered, but I don't want to go down the route of oral therapy, you can use high percentage urea to dissolve the nail essentially. And you have to put it on every single day. And over 3 to 4 weeks, the nail will start to kind of crumble. And then you can put the topical solution onto a crumbled nail. But it's a lot of homework.
Yeah.
But if somebody's really bothered, it does work. And, it's been published and it's been presented at a lot of dermatology meetings. So I have never thankfully given oral terbinafine to somebody who's had a problem, but I have looked after patients who've had a drug-induced lupus from terbinafine and a patient who required a liver transplant from terbinafine for fungal toenails. And for a lot of patients, we were treating psoriasis and they also have, fungus in their nails. And a lot of people get mislabeled as having fungal nails when actually it's psoriasis in their nails. So sometimes you're treating their psoriasis and the nail gets better, but there's still something there. So there has to be a little bit of sometimes fungus. So you can get both together. But I think if I had it, I'd be doing everything I could topically without taking the tablet if I could. But for some people, it's all 10 toenails. It's actually uncomfortable. It's sore in their shoes and they don't have a choice. And we would monitor liver bloods before we give it to them. I usually check them again at a month into treatment, and it's a 3-month course on average, but you have to inform the person that the nail doesn't grow out that quickly. So you don't stay on the oral therapy for a year. You stop it after 3 months, and then it could take 12 to 18 months to grow out a big toenail, and up to 12 months, 6 to 12 months to grow out your small ones. So you're not going to see a perfect toenail on the day you stop your tablets. So you just have to wait and let it grow out. But it isn't 100% success.
No.
Somebody could, and then all of a sudden, 6 months later, it looks like the fungus is back again.
Yeah, no.
So wear your flip-flops and don't walk around in your bare feet.
And that's how you pick them up, isn't it?
Yeah, usually just like that, like swimming pools, even when I go away now on holidays, I'll be like in the hotel, I'll be kind of walking around with my flip-flops on.
With your hat on.
With my hat on and my glasses and my long clothes. Yeah.
Covered head to toe. Nikki, how did you get into dermatology?
So I did Leaving Cert at 17 and then started off 6 years later, went in to become an intern. They didn't offer dermatology as an intern, which is your first year that you do after graduating. It's 6 months surgery and 6 months medicine. So I had to do gastroenterology and cardiology, but I just really liked, I come from family, my mom, family of 10, and I think only one of them doesn't have psoriasis. So I kind of was already familiar with it.
Okay.
Some of my aunts had been in Hume Street Hospital, which was the original dermatology hospital in the city centre. And plenty of them have been on different treatments over the years. So I kind of had it, you know, in the family. And then I knew I loved surgery because I did surgery first for my first 6 months. But I also knew that I wanted a family. And I was thinking, you know, can I be a surgeon and stand for 12 hours in theatre and then another emergency comes in and have a child and never make it home? Like, am I ever going to be able to balance that? And no is the answer. Like, you know, it's almost impossible to try and have that balance. With dermatology, you get to do an awful lot of talking to people, having the chats. And for most time, you're not breaking bad news every day of the week, which is great. It's the worst part of my job, having to break bad news. For the most part, it's obviously skin cancer. It's great to be able to have so many treatments now to offer people to be able to say, yes, we can do something for your psoriasis, we can do something for your acne. But I love operating. So I get the balance of going to theatre Tuesdays and Fridays, chatting away to my patients, doing my surgery, and then I see them all the other days of the week. And to be honest, no 2 days are the same because you've got about 2,500 to 3,000 different skin conditions, of which tons of them I'll never even see in my lifetime. So every day there's somebody who walks in the door with a challenge because you either have never seen it before or it's the pattern is not quite what it should be. And it's a bit of detective work. And I always loved detective novels and programs and all that kind of stuff when I was growing up. So it's the balance, it's the best of both worlds.
Sounds like it. And do you always refer to your other colleagues then as well when you're not sure? Is there a sense of community amongst you all?
Yeah, absolutely. Because, as you know, in our clinic, we have 8 dermatologists there now.
Oh, sure, I'm getting them all in. Yeah. I have someone coming in talking, and we deliberately didn't discuss vulval dermatology here today because I actually have an expert coming in on that.
Fabulous. Yeah. So we have a monthly meeting for our skin cancer. So all of the plastic surgeons, the dermatologists and the pathologists would discuss all of our patients who have skin cancer. So that's the kind of gold standard of care. Anyone who has a melanoma gets discussed at a multidisciplinary team meeting. And then we have another monthly meeting where we discuss the latest journals in dermatology. So that's the American journal or the British or European journal. So the latest treatments for skin conditions, the latest clinical trials, and we discuss our difficult cases. So pre-COVID, we used to bring the patient into the clinic and, you know, all 8 of us would kind of come into the room. But now it's like small room, 1 patient, 8 doctors. Like if somebody gets sick, it's like we all drop. So we now do it virtually. Okay. And we would say to our patients, look, like we've tried X, Y, and Z. This just isn't working. Will we get an opinion of 7 other people? So it saves the patient having to go and wait and see someone else, that we can say, this is the patient, this is what we've tried, or, you know, or this is this really unusual rash, I've never seen it before. And the chances are somebody, you know, has seen it or tried something that works. And it's this sense of community and group coming together to treat. So it's brilliant. It's like a lot of kind of camaraderie. It's great.
I can imagine. And where did you do your training for dermatology?
So I did my 6 years in the College of Surgeons, and then I did 3 years in Beaumont was my intern and 2 years medical SHO. And at that point you're deciding, like, you've done 2 years of medicine, so you're sticking with medicine. You could switch to GP at that point if you wanted, or then you go on to be, you know, like a hospital doctor. So you're then choosing your specialty. Then I did my SHO in the matter, Reg in the matter, and then I got on the specialist registrar scheme, which is 5 years of further just pure dermatology training. So then you're all over the place. So I was in Waterford, Temple Street, Vincent's, the Mater and Beaumont. So my 5 years. And then between that, going over to Scotland. The sunny north of Scotland, which isn't, because I specialise in photo dermatology, which is allergy to the sun and sunscreen and all the products. And it's done in Dundee, of all places. Okay. So I was kind of over and back there and doing research there. So it's a difficult place to get to. You have to fly to Glasgow or Edinburgh and then drive to Dundee. So it's not sunny for the most part, but that's where most of the patients go for their testing. So their photo testing. So then I took up my consultancy in the Mater. And I was there for 5 years, and that's the National Photo Testing Centre. So patients from all over the country would come, and they can only have their testing done in the Mater, which is for, as I said, sun-induced allergy or autoimmune conditions like lupus or photosensitive eczema, things like that. Okay. So they all get special tests there.
Okay.
Yeah, so it's a long road.
It isn't an easy road. It's certainly a lot of study and effort, but you clearly love it. Like, you're here talking to you, you're so animated.
Yeah. Well, I always gesticulate with my hands. I'm like, I could
chat away to you for ages, but I know that we're going to wrap up because I know you've got to get home to your lovely little girl. So I was going to ask you the 2 questions that I ask every guest. So what advice would you give to young people today?
Like, The thing about young people, and I feel there's so much pressure on them these days, but like, to excuse my French, but shit happens. And literally you need to surround yourself with people who are supportive. I have an incredibly supportive family. Like, my parents are like, they mind my little girl, they mind my nephew. My sister's my practice manager. Like, we are a very, very close family. And to say for me where I'm here now, I couldn't have done it without them. So everyone needs help, and life is literally up and down. It's never going to go perfectly, swimmingly. You think you're going to be at this point at a certain age. It just doesn't work like that, and life will throw you challenges. So try and surround yourself with helpful, supportive people. Don't be afraid to, cry out for help, and not to try and be so perfectionistic. Like, I have a type A personality. I am go, go, go. The pressure I put on was always myself. It was never from anyone else. But life throws you challenges and curveballs, and sometimes they then create opportunity. So sometimes we think, oh my God, that's disaster. It's gone incredibly wrong. And then another door opens. So I feel between Instagram and all this perfection that they have, and the fear of missing out and stuff. We didn't even have phones. I got my first phone like when I went to college, and it certainly didn't have that capacity. It was not a smartphone. Yeah. We didn't have that pressure. And I just think they're all looking, and like, the Leaving Cert is like the hardest thing I think you'll ever do. I mean, 6 years of medicine was like a walk in the park compared to the Leaving Cert, because you're studying things that might not be your forte, and you feel like you have to get, top marks and everything. I just feel there's huge pressure. So don't try and stop putting that pressure on yourself, and take time for yourself. I know you exercise a lot. I exercise a lot. That literally is my drug. I don't drink. I don't smoke. And try and find something that you can take time out for yourself, because life is always going to be stressful. You can't be totally stress-free. But yeah, don't be too perfectionistic, thinking that everything is supposed to go swimmingly all the time.
That is sound advice. Now, what is the meaning of life?
So, like, I don't know, you say this to me, like, it obviously means different things for different people. For me personally, and it's because my granddad used to say it all the time, he was like, life is like a long weekend. And it literally is. It's really short. And obviously with the job that I do and looking after patients, thankfully for me, not always breaking the bad news, but my patients will come back to me, and I might not have seen them for 6 months, and something's gone wrong for them, something really serious. So don't take anything for granted like that. Your health is literally your wealth, and take as many holidays as you can. Like, I work incredibly hard. I work long hours, but I always, every 6 to 8 weeks, I'm trying to say, could I even have like a weekend off? Could I take a holiday? Because it really is short. So just try and be positive and as happy as you can, and enjoy every minute, because we just don't know when it'll be taken away from us.
Professor Nicola Ralph.
Because you make so many old work.
It has been an absolute pleasure. Thank you so much for coming.
Thank you for having me. It's great. Thank you.
Thank you so much. Oh my goodness.